All right, let's go ahead and get started. I want to welcome everyone to Grand Rounds this afternoon. So with us today is Dr. Latesha Elopre. She's currently an assistant professor here at UAB in the Department of Medicine in the Division of Infectious Diseases. Completed her medical degree in 2009 at the University of Florida down in Gainesville. After that, she did internal medicine residency at UAB here, an infectious disease fellowship at UAB, and also during all that completed a Master's of Science in Public Health in Applied Epidemiology at UAB. She's also an associate scientist for the UAB Center for AIDS Research, and also serves as Assistant Dean of Diversity and Inclusion for Graduate Medical Education. One element of her research is focused on how to improve HIV prevention among vulnerable populations facing high levels of stigma. Just looking at her CV is very impressive. She's really well funded. She's either the PI or collaborates on a lot of NIH funded grants focused on women's health and the health of historically marginalized populations. So today she'll be presenting diversity in healthcare.
Thank you. Thank you for the introduction. All right, I'm gonna share my screen. And so ultimately for today, when I was approached about doing this talk, initially I said, oh, do you want me to talk about HIV and my research, or do you want me to talk about my DEI work? And I got a resounding, oh, if you're willing to talk about DEI, let's talk about DEI. So when I'm saying DEI, I'm talking about diversity, equity, and inclusion. And overall, this is a talk that I've given to our residents, our fellows, and other health systems, talking about bias in healthcare and why it's important, especially in academic universities that are supposed to excel in innovation, to really tout these as major missions for your academic institution. So these are my financial disclosures. And as was stated, I mostly do research that's funded by NIH, and I also have a Merck industry grant. So the objectives for the talk today is to really understand the meaning of what implicit bias is, talk about how bias contributes to health disparities and what health disparities look like. And then I'll review strategies to improve bias in healthcare, some of which we've implemented at University of Alabama. So I like to start with cases because I think that they're relevant. And this is a patient that I've actually seen. So this is a real case. So this is a 45-year-old man with history of diabetes. A1C is 6.6. They have morbid obesity, high blood pressure. They smoke. They've been smoking for 20 years. And they present to the emergency room complaining of sharp left-sided chest pain that's radiating down both arms, associated with nausea and diaphoresis. The patient reports that this episode occurred while they were walking up a hill outside about 4 hours prior to them coming in to see you, and it gets better with rest, but it's not completely resolved. And they've had similar episodes in the past with exertion, but not as severe, which is why they've come in today. So I'll show you the EKG at the next slide. But besides that, everything else was pretty normal, except they did have an elevated troponin. And you can see the LDL, a TSH, and their chest x-ray, PA, and lateral is normal as well. So in the EKG, you can see they had clear signs of ischemia in those V1 through V3 leads. And the question I would ask all of you is, what, from a textbook standpoint, is typically the appropriate management for this? And some of us may be further away from our internal medicine residency training, but this is really typical and categorical of what we think of when we think of chest pain. So would you get a left heart cath, so refer them immediately? Would you do a stress test and see if that was consistent with ischemia? Would you observe them in the hospital and monitor them to see if their troponins continue to rise or stabilize? Or would you discharge them out to go see their primary care provider? So let's think about this question revisited. And if you're willing to and you're open to, either close your eyes or just think about in your mind's eye what this patient looks like as they're sitting in the bed and you're taking care of them and you're making this decision. So my question is, would your care change if this individual was Black? Or did you already see them as Black? What if this person was a transgender woman? What if you knew this person was living with HIV? How would that change your management or the feelings you have about this case? Or if they report having active history of substance use disorder, last crack cocaine use was a day prior to being seen. So for this patient, what really happened is they were monitored in the hospital for 48 hours and they were sent home to see me. I'm their primary care provider. I ordered an outpatient stress test, which did show ischemia. They had to get a left heart cath, and they had 70–80% focal stenosis, and had to get a drug-eluting stent placed for that. So ultimately, this is a classic case of what I want us to talk about, which is what bias looks like. Because for all of those, especially for things like, for me personally, substance use disorder, when you read a chart and you know a person's history, it automatically can change the lens through which you see them, your differential diagnosis on how they present, and the care that they receive. And for this patient, it did do those things. And luckily, they still got really what could have been life-saving interventions, but had not they come in to see me, what could have happened to them? So what is bias? So the most common type of bias is implicit or unconscious, meaning that we are not aware that these biases occur. And these are split, usually decisions that we make that are associated and attributed to stereotypes that we typically hold about a group of individuals. It's our understandings, our actions, our beliefs, and our feelings that we have about those individuals that's oftentimes unconscious. And these biases can be favorable or unfavorable. So when we're talking about stereotypes and what are common stereotypes that are, textbook examples, if you have someone, like I said, the history of substance use disorder, what are your thoughts and feelings that automatically pop up when you think about that? Same thing if you think a classic one that's considered a good stereotype, which really no stereotypes are good, but if you have someone who is of Asian descent, you think, oh, automatically they're hardworking or they're good in math. Like, these are not things that are uncommon, but oftentimes are unconscious to us, meaning that we make these decisions without even realizing we're making them. So all the things we're talking about is bias. And the important thing to realize is that these thoughts that you have that are unconscious automatically shade and affect the decisions that we make without question. And oftentimes, like I said, when you're not aware, and there's a really good book that you can read about this called Blink that talks about these split decisions that we make within our brain that has ultimately, in a lot of instances, protect us and has evolved over time as almost like a fight or flight response. And because we have these unconscious biases and these beliefs that we have in regards to a lot of times marginalized individuals from historically disadvantaged backgrounds, it shades everything in which we engage our environment and the behaviors that we have related to the people who are from that culture, from that subculture, from that geographic location within the country, from even an institution or an educational background. Something that's very common that I talk about when we're doing our residency selection is what we're willing to do for individuals when we know that they've come from an Ivy League institution. So a C from Harvard, is that the same as an A from Kansas City State University? So once learned, it's very hard to change your preconceived notions or beliefs about a group of individuals. And when you have negative feelings attached to these beliefs, that leads to prejudices. And that's technically what a prejudice is. It's that emotional feeling you have linked to the stereotypical beliefs that we hold about a group of individuals. And when we act on those prejudices or beliefs in a way that's inequitable or unfair, that is discrimination. So again, why do we do this? Is this something that makes us bad inherently? No, this is something that happens within everyone's brains, and oftentimes it happens in less than 1/10 of a second for you to form an opinion, whether it's positive or otherwise, on someone that you just recently met and you're newly acquainted with. So in fact, these snap judgments are so powerful that in cases where we have a lot of information about a person or situation, our snap judgments oftentimes overpower our decision making. And again, the example that I gave you from that case where you had all this information available to you, potentially the biases we have around people who have those multiple stigmatized identities can ultimately impact and impair our ability to offer standard of care. So there's tons of different types of biases that we all have. And like I said, they can be positive or negative associations about a group of people based off of their characteristics. And they can range Oftentimes and historically, we've always thought about this in regards to race and ethnicity, but it can be related to age, your social class, someone's sexual orientation or gender identity. And all of those groups can be prone to stereotypes. And over time, these stereotypes can become so ingrained and habitual that it essentially makes other things that we learn about individuals ultimately invisible to us. Invisible stereotyping, we automatically begin to categorize individuals as members of a certain social group. So if I see someone outside who is a Black man with a hoodie on, would I automatically assume that because of my predetermined beliefs about individuals who fit that characteristic, that this person is violent or they might be dangerous? And we know just from what we've seen in the news, this is something that we're currently still dealing with in society. So what are different types of biases? The most common is confirmation bias. So if you already have a prejudice or a set of beliefs about an individual or a group of individuals, and they behave in a way that confirms or reinforces that belief, it's like an aha moment, making that belief even more strongly rooted within us. So if we meet somebody that we automatically think, oh, these individuals or this group of individuals are lazy, and then they behave in a way in which we think, oh, well, this is reinforcing my belief that they are lazy, then the stereotypes for that group of individuals become strengthened, and it justifies the reason why we had those beliefs to begin with. The other and the most common type is blind spot bias, and this is what most people are guilty of. This is the belief that other people have far more biases than we have, and it causes us to be blind to the biases that we hold ourselves. So there is tests that you can do that talk and teach you about the biases you may hold that are split second unconscious biases. But what they found is that when they survey individuals asking, hey, what do you think of the bias that you hold compared to other people? 95% of the time, people think that everyone else has more biases than they have. So, does this just occur in medicine? The answer is no. So, I'm going to give some examples that have been, I think, mostly known and popularized about how bias impacts just everyday life when you're looking at people getting jobs. This is a study that was done looking at race and resumes. Researchers developed a set of 4 resumes for job applicants, and they either had a white sounding name or an African American sounding name. They had everything else within those resumes the same. And what they looked at is, were these individuals more likely or less likely to get an interview? And what the study ultimately showed is that if you have an African American sounding name, you're resoundingly less likely to be offered an interview. Another example of unconscious bias or implicit bias that we found is looking at the motherhood penalty. So this is a study that was done looking at 192 participants, both men and women, evaluating pairs of equally qualified job applications. And when they were assessing pairs of women, and evaluators judged mothers ultimately to be less committed to their jobs. And this is something that has been really routinely rooted out when we're talking about the ability to ask people if they have family, but unfortunately still penalized for. And I've been in rank meetings, even within our own institution, where we've talked and potentially looked at people who have kids in a less favorable manner, especially mothers, because we feel like they're not going to be able to commit to their jobs. And then the idea of a positive stereotype. So there's been studies that have shown that fathers actually get a bonus, and they're actually sometimes reviewed better when you're looking at applications. So fathers are oftentimes more recommended for jobs. They're more likely to be hired. They often have higher starting salaries, and they're more likely to be promoted. And this is another example, and I'm just doing this over and over again to show that this is something that is pervasive and common throughout multiple business and fields besides just medicine. But again, another time where you're looking at identical errors in memos, but really people who are of African American background compared to white individuals, when they're the author of those memos, are reviewed much more harshly. So I'm going to skip this because I want to make sure that we have enough time to talk about I'll say this example. So these are the comments that were made in the study where they looked at the memos. And when they looked at the African-American memos, it was, oh, this person needs a lot more work. Can't believe he went to NYU and this is average at best. But when they looked at individuals who were white, it was, oh, generally this is a good writer, but they need some work. This person has potential, good analytical skills. Okay, so how does this play out in practice? I'm gonna skip. Yeah. So let's talk about bias in healthcare. So I think most people are aware of the socio-ecological model, talking about how factors that patients have and their backgrounds and the environment in which they live impact and impair their ability to always have the same healthcare access and healthcare outcomes. And when we look at this in multiple levels. So at the individual level, the first level that we really look at is those biological and personal factors that can influence health. And these can be related to age, someone's health, income, their history of having a substance use disorder, like in our patient, or a history of abuse. We look at it in the interpersonal level. So this is the second level, looking at relationships that individuals may hold. And this is really people that are within their network or inner circle, their parents, their family members, their partners, and how those relationships can impact and impair and influence health and health outcomes. Community is the third level. This is schools, workplaces, neighborhoods. So if you have someone who has high levels of neighborhood violence, how does that impact their healthcare? And I can give a very concrete example when we're talking about sending people out on antibiotics. And we say we want Q12 antibiotic dosing for these IV antibiotics. There are some home health agencies based off of the neighborhood in which our patients live who won't go to those neighborhoods past 3 o'clock in the afternoon. So they're not really able to get the standard of care that we prescribed. And then public policy, looking at really things like laws, health insurance plans, economic and educational systems that can impact health and health outcomes. And then there's actually something called the Social Vulnerability Index that directly links and looks at, from a geographic standpoint, how vulnerable are you to having poor healthcare outcomes? And as you can see within our state, there are some very, very high levels of vulnerability, especially mapped across the Black Belt. And that's why so much emphasis has been placed on focusing on health disparities within these regions. So, bias in healthcare and clinical settings, which is what I think we really care about and we want to know how we can improve. So we actually have very many concrete examples of how health is impacted by things like race, ethnicity, and a lot of other vulnerable and oftentimes stigmatized identities that our patients can hold. There's over 42 articles that have been published up to this point in time showing that implicit bias in healthcare has deleterious effects on patient outcomes. And just some quick examples are things like showing that if you were to have all things the same between a Black mother and a white mother coming in to give birth to a child, the Black mother would still have higher mortality rates and infant mortality rates when they deliver. One example that's been publicized recently is this idea of pain. They actually did a survey where they talked to medical students and asked them, do you think there's a difference between biologically how people perceive pain? And the students actually said that they thought biologically Black people had thicker skin and were less likely to feel pain compared to white individuals. So bias in clinical settings affect our patient and provider interactions, the treatment decisions we make. So in that example, talking about pain, we know that a direct link to the current opioid epidemic and the epidemiology we're seeing around that, primarily in white communities, is because of likely the bias that healthcare providers have in regard to prescribing pain medications and narcotics to Black individuals and brown individuals from marginalized communities. Patient treatment adherence. So there have been studies that have shown that patients are more likely to adhere to regimens that we prescribe them if they feel like their physicians recognize and are culturally humble and conscious of their own biases. And as I said, it's directly linked to patient health outcomes. And so one of the biggest things that we focus on and we talk about when we're talking about all of these different levels that can affect patient outcomes is, from identity standpoint, race, because historically speaking, that is how we have really, especially within the United States, separated out and attached value to individuals, but there are tons of different other ways that people can be marginalized and stigmatized against related to, like I said, their sexual orientation, whether they're able-bodied, their gender identity, our views on people who are married versus not married, people who live in the South versus the North. And all of those biases can interplay and impact the health outcomes of our patients, especially here in Alabama. So when those things occur and we have inequities in the care that people receive, this results directly in things like health disparities, which specifically is the kind of health differences between more and less privileged groups. It can lead to health care disparities, which is systematic differences in health care received by people based off of hierarchies. And differences that we find are not random. These are systematic differences, and they are amendable to social interventions. So here's one example just of what health disparities look like. And this is looking at infant mortality rates based off of race. So we know clinicians are more likely to consider Black patients less compliant, less cooperative than white patients based off of studies. And we know that we think that they're less likely to adhere. But even something as simple as women coming in and giving birth to a child, looking at overall mortality rates, you can see that Black infants are 2.3 times more likely to die in the first year of life compared to white infants. And I think the thing that is shocking is that these have not improved over time. If you look at this data from like 1970 to now, we've had very little improvement when we're talking about infant mortality, especially in regards to Black infants. So how does racism directly impact health outcomes? And there's a lot of conceptual frameworks that look at this, but I like this one because I feel like it's one of the most comprehensive examples. And it talks about the fact that when someone is faced with racial discrimination and they're interacting with the healthcare system or within an environment that is inherently racist, they are more likely to have physiological stress that can lead to negative coping behaviors, leading to mental health illness related to anxiety, depression, substance use disorder, but importantly, physical health outcomes that can be worse in relation to cardiovascular disease, decreased birth rates like we talked about, and increased blood pressure. There's also a physiological stress response. So there have been studies that have shown higher levels of cortisol in individuals who report racial discrimination, either experienced or perceived, and these can directly be linked to these negative health outcomes. And then looking at just from a standpoint of social determinants of health, if you have racial discrimination leading to denial of goods or resources, you might have poor living conditions, less access available to you, which leads again to these worse outcomes. And COVID-19, I think, is one of the most relevant and pertinent examples that we can talk about right now, where we're currently seeing that Black and Brown communities are 3 to 4 times more likely to die from COVID if they're hospitalized when you're looking at majority populations. And these are news clippings just showing some of the biases that people have and how likely these can impact some of the outcomes we're seeing in regards to COVID. So one of the ones I like to highlight is this Ohio state representative who's an emergency room physician who says that colored populations are more likely to not wash their hands, and that's why they're more likely to get COVID. These are real things that have been said that are relevant. And this is an example, I think, of not unconscious or bias, but explicit bias. And this is something that's more easily identified. But again, we need to recognize that we still have a lot of times unconscious biases and positive intent going into healthcare that we're not even aware of our biases impacting the healthcare that our patients receive. So I'm going to shift now. I always do this with the quote from James Baldwin: not everything that is faced can be changed, but nothing can be changed until it's faced. So right now, we are aware of just the tip of the iceberg in regards to our biases, but there's a lot underneath that we have to unpack and understand in order to improve health outcomes. And one way to do that is through DEI initiatives. So in talks that we give, we like to talk about cultural competency. And this idea has really shifted in what it means to be culturally competent. At one point in time, we thought that you would get a gold star at some point and say, aha, I did it. I understand culture and the culture of many different people, and now I'm competent. And that suggests that you no longer need to study, do self-evaluations, or feel like you need to change. So a lot of people have changed the terminology around this to being sensitive to other people's cultures and being humble, meaning that you're always willing and ready to learn. And for physicians, this is a definition that I really have enjoyed sharing with other individuals, the ability of individuals to establish effective interpersonal working relationships that superseded cultural differences by recognizing the importance of social and cultural influences on patients, considering how these factors interact, and devising interventions that take these issues into account. And the reason why I like this quote and this definition of what cultural quote unquote competency looks like for a physician is because it focuses on the need to devise interventions. So how can we overcome implicit bias? There's tons of different ways. One is having these types of workshops where you're raising awareness about what implicit bias means. But another thing is diversifying your workforce so that you're having more conversations, you're interacting with people who are from different backgrounds. Not only does it change the work environment and space in which we grow and learn, but it also can improve our patients' outcomes as well. We should always try to practice evidence-based medicine, knowing our own biases, stop ourselves and pause, for example, in the case that I presented, and say, what is standard of care for this individual, despite these potentially marginalized backgrounds that this individual holds. So one way that you can learn about your own biases, and this is somewhat of a controversial test, but the implicit association test. And the reason why I say it's somewhat controversial is because there's been questions regarding whether if you find that you have these biases, they actually are associated with behavior change. But overall, I think that this is one way that you can get a lens into yourself that looks at different forms of biases. So for instance, you can even look at bias related to obesity. You can look at bias related to gender, someone who's able-bodied versus not able-bodied. And it actually tells you if you view individuals the same based off of split-second images they show you and the descriptors that you give to those images. So once you learn and recognize your own biases, there are strategies you can use to mitigate those biases. So one is to actually ask our patients and get feedback from our patients about whether they feel like they are getting care that is not biased or not influenced by prejudice leading to discrimination. There's ways that we can check in with our own emotions. So looking if we have a negative emotion related to a group of individuals, trying to understand and recognize that and take, again, a pause to think about ways that we can change our behavior or how that may be influencing our behavior. And then have partnership building skills. So if you are working with a team of individuals that are very passionate and engaged and focused on rooting out biases and understanding how we can improve healthcare disparities, having those check-in with those individuals can help you have a support system in this journey, but also learn from each other. So one of the biggest things that we're really trying to do, again, is diversify our workforce. And we know that diversity matters. There's been tons of studies showing that there's educational benefits when you have diversity within a system focused on teaching and innovation, like our institution. Relationships benefit. We have a more representative workforce for the patient population we're trying to serve. We know that patients are more likely to be served by diverse individuals and physicians and care providers, just historically and from demographic data that we've looked at in the past. You're more likely to have a social justice framework when you're talking about approaching a patient or a problem within your institution. And it's really, I think, a statement of the fact that you are willing and able to have a service commitment within your institution as well. So what we know, unfortunately, is that while we are striving to have more diversity in our workforce, it's not something that we're doing a very good job of across the board, not just at UAB, but multiple institutions. So Black people, when you're looking at the US Census, make about 13% of the population. If you're looking at Latinx individuals, it's about 18%. And then if you're looking at the actual workforce, especially for our providers, you can see that in medical school, very few African-American, which is this green box, 6.2% are Black, and Hispanic, which is 5.3%. If you're looking at active physicians, this number actually in percentage decreases. So Black is only 5% in this pie graph. And if you're looking at people from Latinx communities, again, it's 5%. And if you're looking at full-time US medical school faculty, so at an academic institution like our own, it's even worse. So it's 3.6% that are Black. And if you're looking at Hispanic, again, it stays at 5%. So why aren't we, I think, meeting the diversity benchmarks? One of the things is that we have to strengthen our pipelines. If you look at that graphic and looking at the disparities in how many people within our US population are Black compared to the number of individuals who come and practice medicine, especially at academic institutions, there's already a disparity there. One thing that we can also do is try to tout ideals that focus on and are centered around anti-racism. So if we are witness to someone who might have an unconscious implicit bias, and we think that it's impacting the way that they're engaging with a colleague or a patient, we can try to call them in and not call them out. And this is one way that we can try to improve the inclusivity of our institution. So to call in means that you aren't calling out somebody saying, hey, I think that what you're doing right now is potentially racist, or you're prejudiced, or you're discriminating against somebody. It's saying that we understand that this is unconscious most of the time. Most people have positive intent, and it focuses on that behavior. So if you were to witness something where someone said something disparaging about a group of individuals, or in this case, in the case that we presented with this patient, recognizing that maybe this patient might have received worse care, not standard of care, because of the multiple stigmatized identities they have, call someone in and say, hey, I want to talk about this patient decision that was made and what my thoughts are about it. And I want to understand what your thought process was. And through this discourse of mindfully listening and trying to understand and unpack behaviors, a lot of times you can get to shared decision-making, shared goals, and a change in values. And sometimes if we can't get all of that, we can at least get a change in behavior. The other thing I want to talk about was this idea of anti-racism. There's a great book that's oftentimes backordered on Amazon, but it talks about how to be anti-racist. So how do you understand the definition of what racism is? And again, a lot of times this is rooted in unconscious biases and prejudices that almost everyone holds. And the important things that they point out in this book is that we have to stop saying, I'm not a racist. We have to recognize that we all have these biases and work to unpack systematically within our institutions and within ourselves these racist ideals that we have and how they potentially change the behaviors that we have. So identify racial inequalities and inequities, confront racist ideas, and understand how anti-racism needs to be intersectional. So in the example that I provided, again, understanding that the fact that my patient was Black, transgender, had a history of substance use disorder, was living with HIV, all of these stigmatized and marginalized identities likely compounded the negative feelings that potentially may have led to that individual not getting standard of care. And then as a provider, it's important for us to, number one, if we're saying we want to recognize our biases, focus on becoming an anti-racist, understand that there are zones that we're going to constantly be in. So, and having DEI talks, a lot of times people are going to be uncomfortable, and it's okay to be uncomfortable. Strive to be uncomfortable, and be okay and comfortable with the idea of being uncomfortable, because we can't grow if we're constantly denying that we have these biases or potentially prejudices that are impacting patient care, our interactions with our colleagues. So we need to move from that zone and learn. And that means educating ourselves, reading, attending workshops, listening to podcasts, and interacting and engaging, expanding our social network so that it is more diverse. And then ultimately continue to grow. And that means that we become champions and we're educating and calling in our colleagues. And then I think the important part that this graphic doesn't show is this isn't a unidirectional path. You oftentimes will fall back into an uncomfortable zone and have to recognize that it's okay to be there. So this is a relatively brief talk that I typically give because I want to open up for questions and discussions. But that is my talk, and I can talk more if people are interested about what we're doing at UAB to improve diversity, equity, and inclusion, especially within our residency program. So thank you.
Thank you very much, Dr. Elopre. Really excellent talk. we've heard a fair amount about it in the past year or so, but certainly never enough. So we really appreciate your time and willingness to talk about these things, and also your leadership at UAB to help us understand these issues. Sometimes we have questions in the chat. We don't have any at the moment. If anybody has any questions or comments, feel free to speak up. And if not, we have several minutes. If you don't mind talking a little bit about some of the work that the subcommittee is doing, maybe opportunities for people like us in pathology to be involved in some of these initiatives. You can go into some of that.
Yeah, I've been really, I think, proud of the direction that UAB has gone in strategically trying to address and improve diversity, equity, inclusion within our institution. So from a residency standpoint, we've actually done a deep dive and analysis trying to understand how our residents and our trainees interact and engage and perceive their environment at UAB. So we've done interviews with them to ask, how's your experience been at UAB? Have you had any bad experiences related to your race, ethnicity, gender identity, you being a part of the LGBTQ+ community? We've actually talked to all of the program directors from main match programs to find out what goes into their process when they're going through interview season, inviting people to interview, ranking them. And then we've talked to experts in the field external to UAB to find out what their best practices are related to DEI. And from that, a strategic plan was made where we came up with recommendations, really 10 recommendations on how we can improve diversity within our residency programs specifically, and how we can try to have a more inclusive environment. And I would say that something that has been a shortcoming of and potentially short-sighted is that we focus a lot of times on diversity and just improving numbers, but not really focus on the environment in which people train and live once they get here. So something that we were struggling with is even when we were improving our numbers, when people were here, they weren't staying. And so I think that right now, the biggest thing we're trying to do is really focus on the culture of UAB. So the things that we've talked about and we do now is we have conferences that we at GME office will help pay for, like SNMA, LMSA, and at historically Black colleges and universities to raise awareness about UAB and try to answer questions about UAB. There's a second look that people can attend. From a interview season standpoint, we provide for all of our main match programs their numbers, looking at from the time that someone applies to where you've matched them to them ranking to match, what the demographics look like within your own program and how they've changed over time, and then stratify that information based off of things like step 1 scores. And then we always like to really, I think, promote the idea of holistic review. And there's one department that's really done this well, which is Department of Surgery, where they have looked at the mission and values for their department and removed some of the, I think, objective data that we have looking at things like AOA status and whether someone has step 1 scores that are high and who they invite and rank in regards to their residency programs. So those are some of the things that we've done. And hopefully over the years, like I said, our numbers are improving, but our goal right now is to really improve the environment in which our trainees are currently practicing.
There's a couple questions in the chat. Unless if Brandy or Greg had a question, y'all are welcome to go. You're on mute.
I have a question, but I'm not telling anyone. Am I?
We can hear you.
Okay, good. It wasn't clear to me now. So this is my question. So there's a whole nother aspect. It's always seemed to me in medicine, there's a whole nother aspect of prejudice and bias that exists, and that's from discipline to discipline. And I'm sure that everyone knows jokes about this discipline or that the same as I do. And is there any thought that somehow that practice, which is pervasive, is somehow tied up with other types of prejudice or biases? And any thought of trying to address it?
Yes. So I wouldn't say there is a process or a thought right now on how we can improve that. But no, there's definitely prejudice and biases related to different programs, different training programs, specifically like if you think about OB-GYN, we've had some people report that they don't feel like always as a male who's interested in OB-GYN, that that's something that's available or open to them. Is that what you're referring to?
No, I'm talking about things like surgeons who say, if you don't go into surgery, you've wasted your entire medical career. Nothing counts but surgery, or internal medicine, or what have you. Some specialties saying and that's fine. I mean, I'm a pathologist. I chose pathology over everything else. So clearly I have a soft spot in my heart for pathology. But that doesn't mean if I break my leg, I don't want to see an orthopedic surgeon, although I don't want to be an orthopedic surgeon. But I think that which we all experience and live in and even tolerate, and in some ways kind of enjoy, that jocularity back and forth, nevertheless, that has created a milieu that would encourage other sorts of prejudice and bias. That's what I'm referring to. I don't even know how to begin to address it.
Yeah, I would have to think a lot more about how to begin to address that, because that's something that has formed over decades. What you're talking, and I think that it does impact and bias in regards to who we think fit within each one of those fields as well, and how we're talking to medical students and promoting different fields of practice. So that's a great point, and I appreciate you bringing it up.
Well, thank you. And thank you for your presentation.
And I'll make a comment about that, Greg. I wonder if sometimes people are saying something that they think will be funny, or it's in a joking kind of way, but then don't know some of the unintended consequences of that kind of thing, about maybe disparaging another fellow or another specialty or something like that. So maybe it's always being cognizant of how we're coming across, even if we don't intend on certain things. Sort of maybe an underlying issue in certain types of biases. But there are some questions in the chat. One of them says, if there's no one to point out it out to us, how can we tell we are subconsciously judging a certain group or race?
I think that's the key in regards to doing that introspection and trying to look at your own behaviors and check in with your own biases. So that's why I shared the IAT as one way. Personally, as a provider, I try to learn and understand my own biases. So when I'm interacting with a patient and I have a feeling about that patient that may be a negative feeling related to identity they hold, like I talked about substance use disorder, recognizing that and thinking about how that could impact my decision making. But all in all, what I'll say, and I think this relates also to kind of what Greg is saying, all of these biases that we have are pervasive. They're everyday occurrences. And that's why I think having practices that we can learn, like bystander training and calling in when you witness somebody acting on those biases potentially, will help to change culture. It's not our goal to say that no one's ever going to experience discrimination, because right now that's just not where we are. Like, people are going to experience discrimination related to multiple identities they may hold. I think the goal is, number one, we're in an environment where people feel comfortable and confident to call out behaviors that may result in discrimination, and know that the institution supports them if they've experienced that as well.
All right, next question. Could you please tell us about some of the efforts taken at UAB to stop attrition from medical school, and also in some of the, maybe the GME or the fellowship programs?
So, there's tons of stuff that's being done. One thing I talked about was pipeline programs. There are so many pipeline programs at UAB that focus on high school students, healthcare academies within some of the Birmingham City schools, 3 specifically, to expose people to health sciences, and pipeline programs that partner with historically Black colleges and universities, trying to do early acceptance programs. And once they get here from a college that might not have the same resources as a big institution like UAB, supporting them so that they can be successful in passing the test and doing well in step 1, so they can attain their own professional goals. So there are tons of things that the medical school is doing to improve and retain and ensure that people who are from underrepresented backgrounds, like first generation college graduates, people coming from rural institutions, do well once they get here. What we're still struggling with is once we have medical school students coming from diverse backgrounds, making sure they stay here, that the experience they have while they're training here is a positive one, which is why we're focusing on doing these types of workshops and talking to people who engage with our students, because I think that's probably the biggest predictor for them staying on and coming.
Hey, Dan, I just want to weigh in
Go ahead.
here if I can. I just figured some of the people on the call might be curious about what we actually do here. I'm Dr. Elopre. I'm sure you've seen me around. I'm the program director, and so I've gotten some of the reports from the subcommittee from GME. But just I want to build on what you just described about pipeline projects and programs, just to let everyone on the call know what we do here in the department. We have a Race for Path summer program that exists for pipeline to research within our department that targets undergraduate students, particularly underrepresented minorities in medicine. We also have that program that exists for medical students too. So hopefully we can sort of build relationships and retain people through that experience. And then also working with the medical school, we have an integrated residency program now to try to capture some of those interested students in the medical school. Eventually, hopefully we capture them early in the undergraduate process too. Our residents have worked with the other summer programs that exist, particularly Dr. Samant's project that they work with in the summer, which is the Birmingham City School project that has high school students coming in the summer. So our residents are involved in that to introduce them to pathology as a career early on. And then just some of the efforts we do during recruitment. We do not release any photographs. So I primarily screen all of the applications myself. I'm blinded to any photograph to make sure that I don't introduce any bias from that aspect. I also blind all of my interviewers to the full application packet because I do not want them biased by anything regarding academic grades, leave of absences, anything that could exist that permeates through the ERAS application. I try to keep that limited to to myself and do not let that out to the interviewers. All the interviewers get a relatively standardized bio or blurb that has similar characteristics for every applicant. Of course, other information is available if people want it, but I try to limit that as much as I can. And I think that has served us well so far. We started that last year and we're doing it again this year. Additionally, one of the more unique experiences that our applicants undergo during the interview day is a structured or standardized interview. Which is a couple of the people on the call actually are raters for that station. I'm happy to talk to anybody about that. But the goal is to provide a standardized experience for every applicant, regardless of their background, to succeed. And they actually do that in a blinded manner, meaning they don't get any feedback from the rater. The rater is assessing them from essentially the dark room, as my first year residents referred to it last year. So I just kind of wanted to close the loop for everybody that, since some of you on the call are involved, I actually see a couple applicants on the call who have gone through that process themselves and are joining us from afar. But I just kind of wanted to close the loop so you guys knew what we were actually doing here in the department. And if any of you are not involved in any of those things that I've mentioned and you want to be involved, please do let me know. But we are trying very hard to have these conversations regularly and make it something that we can all lean into, that growing edge a little bit. So just wanted to add that. And thank you so much for being here.
No, that's fantastic. And I will say that's something I've also just been so happy about being at UAB in regards to the leadership within our programs. So from 2018 to now, all the steps that the program directors have made to do things like blinding people to pictures, to gender, to things like AOA status, which has been shown to be a biased practice within itself, like who's recommended for AOA, has just been fantastic. And I think that that type of growth shows that people are, like I said, they are really holding on to these ideas around anti-racism and how can we at our university have a more inclusive environment. So I've been super pleased working with all the program directors and being able to get that feedback that people are actually putting forward change is great.
Okay, any more live questions, or do you want me to get some of these in the chat? All right, Dr. Mann asks, although diversity has its benefits, are there any challenges like reverse discrimination?
So it's a really interesting question. And I would hold, when we're talking about the idea of reverse discrimination and talking about, I think sometimes the discomfort that majority populations can feel as we're moving towards these conversations around DEI are really important to just be upfront and honest and open about. Ultimately, this is the analogy I typically give, when someone is standing next to a puppy and you see that the puppy is dirty and you say, oh, that puppy really needs to be clean, but you don't want to get dirty to clean the puppy, then you're not actually trying to get the puppy clean. So that's like a oversimplified example of how I view programs to improve equity. So if we're talking about improving equity, you can't say, unfortunately, I want to have more diversity. There's not an infinite number of slots. There's a finite number of slots. So if you're talking about diversifying those slots, I want to have a residency program more representative of the US population, not even like this within the state of Alabama. That means that one group has to get smaller. Does that mean that there's not other opportunities for individuals within that group? No, but as we're espousing and saying our mission is to have diversity because we know diversity is excellence and it fosters environments where innovation occurs. That is one of the things that we have to understand and hold on to, is the fact that our goal for a student body, a residency class, may change because of that. So I don't look at it as reverse discrimination. I look at it as really the idea of equity.
Great presentation. Did the AAMC report talk about reasons for a decrease in Black faculty? Is it a problem with retention or burnout?
So there's been a lot of studies that looked at not only decreased numbers in regards to looking specifically at Black male medical students. So we had more Black male medical students in the 1970s and 80s than we have now, but also looking at Black faculty and specifically academia. So a lot of Black academicians leave universities and institutions because they oftentimes feel like they are not getting exposed to leadership opportunities. They're less likely to be promoted and they're less likely to be paid equitably. And there's been tons of analysis that have shown this, and not just with race and ethnicity and with Black faculty, but also based off gender. And so I think that those are primarily the things and some of the factors that have been associated with people leaving and not being retained in academic institutions and keeping their faculty positions. And some of the things that can be done to fix that is try to look at programming again to support things like promotion and tenure, and to actually do analyses with that social justice framework, understanding that a lot of our systems are already unfortunately affected by racism or discrimination. Say, we understand that, and we're gonna systematically look at our systems and figure out how we can dismantle that. So does that mean we're doing a review of all of our salaries to say, are these equitable? Are people being paid the same? Or we're doing a review of our residency programs or our fellowship programs to say, are we seeing differences in who's being offered an interview or who's being matched? Those are the types of, I think, interventions that are needed to improve that.
Thank you. Monica says residency coordinators at the APC, that's the Association of Pathology Chairs, meeting were very interested in our dark room and our attempt to eliminate bias during virtual interviews. So making some waves in pathology with GME that we're proud of. Any more questions? And put it in the chat or feel free to speak up. If not, we got about 4 or 5 minutes. I guess that's it. Thank you very much, Dr. Elopre. It was really, really good and really appreciate your time.
Thanks for having me.
Well, there's one question if you want to answer. Just kidding. Okay. In what ways can residents contribute to strengthening the pipeline of medicine for those who identify as underrepresented minority? What resources are available to residents at UAB to assist with this? So you got 3 or 4 minutes.
No, I'm actually super excited about this question. So we have the DCGME Subcommittee for Diversity, Equity, and Inclusion. You can contact myself, Alice Getford, who leads all of our GME and all of our trainees. You can contact Justin Evans or anybody within GME office really to say you want to be a member of that subcommittee. The other thing is we have a URIM house staff. For the house staff, we have a new director that's about to be named, Dr. Samantha Hill, who's going to be leading initiatives to improve professional development, culture, and networking within our URM house staff, and that will include residents and fellows. They have 2 seats automatically on the house staff board that we currently have at our institution. So their voices are heard through that as well. If they feel like there are policies or initiatives that we need to push forward to better improve training for people who are underrepresented in medicine. So those are some things that you can do if you're interested.
Thank you very much. Appreciate it.
Bye, everybody.